Hello everyone. Today I'll be explaining in brief about the non-pharmacological behavior management techniques. Okay. So there's a famous quote by McElroy which says that although operative dentistry may be perfect, the appointment is a failure if the child departs in tears. Okay. We need to learn behavior management to understand the child better and to communicate with the child better to make the child have a positive attitude towards the dental treatment. Okay, so there are these three basic terminologies which we need to know. Behavior management is the means by which the dental health team effectively and efficiently performs treatment in a child and at the same time instills a positive dental attitude. Okay, then there's something called behavior shaping. It is the procedure which slowly develops behavior by reinforcing a successive approximation of desired behavior until the desired behavior comes into being. And then comes a behavior modification, which is the attempt to alter the human behavior and emotion in a beneficial way and in accordance with the laws of learning. Okay, so these are the three basic terms which we need to remember. The objectives of behavior management, the main aim here is to instill a positive dental attitude and create a long-term interest on the patient's part so as to facilitate the ongoing prevention and improve dental health in future. Okay, so the main objectives are to establish effective communication with the child and parents, to gain the child's and parents' confidence and acceptance of the dental treatment, to teach the child and parents to have a positive aspect, to know the positive aspect of the preventive dental care, to provide a relaxing and comfortable environment for the dental team to work while treating the child patient. Okay, the fundamentals of behavior management are to have a positive approach, the team attitude and organization, truthfulness towards the child and the parents, tolerance and flexibility. These are the basic fundamentals. Okay, then comes the behavior management techniques. They can be broadly categorized into pharmacological, non-pharmacological. So the non-pharmacological ones which we will be discussing today are the psychological and the physical ones, and pharmacological are the ones which use drugs. Okay, in which conscious sedation, nitrous oxide, all the other intraoral drugs and even general anesthesia, they fall under pharmacological. So we'll be discussing about the non-pharmacological ones. Okay, so psychological approach includes all these: communication, tell, show, do, voice control, biofeedback, audio analgesia, desensitization, modeling, contingency management, hypnosis, coping, distraction, timeout, etc. Okay, I'll be discussing all these in very brief. So behavior modification and pre-appointment behavior modification. There's something called as pre-appointment behavior modification. That is anything which is said or done to positively influence the child's behavior before the child even enters the dental operatory. This is very important because the first dental visit is crucial in the formation of the child's attitude towards dentistry. Okay, so the first dental visit has to be as pleasant as possible for the child. Therefore we need to prepare the child beforehand, even before the child enters the dental operatory. Okay, so pre-appointment behavior management can be done by audiovisual aids, films or videotapes. They are developed, okay, which provide information to the child. There can be someone doing modeling for them, can be performed with a live patient, live models like siblings, children or parents. Pre-appointment mailing, where we pre-contact the parents and provide directions for how to prepare the child for the initial dental visit and therefore increase the likelihood of the successful first appointment for the child. Okay, behavior shaping, like I told, it is a procedure which very slowly develops behavior by reinforcing successive approximation of the desired behavior until the desired behavior comes into being. It is also called stimulus response theory because it's based on that stimulus and response connection. When shaping behavior, we are teaching the child how to behave by leading the young children through procedures in a step-by-step manner. Okay, excuse me. Then comes communication. The basic ways of communication are verbal and non-verbal. Okay, verbal communication is through conversation. By involving the child in a conversation, the pediatric dentist not only learns about the patient but also relaxes the youngster. Okay, so you have to talk to the child. Generally, verbal communication is best initiated for younger children with complimentary comments. You can always give them compliments of about what they're wearing, okay, and then followed by questions which elicit answers other than yes or no. So rather than just asking them straightforward questions, you can ask them uh, questions where they have to answer in a sentence form rather than yes or no. Okay, like you can ask the child what they had for their breakfast, if the child is coming in the morning for an appointment, okay, all those things. So that establishes a communication between the doctor and the child patient. It is important that communication occurs from a single source. For young children, for them it's very difficult to concentrate if two people are speaking together. They get confused. Okay, so it has to happen from a single source. And to improve the clarity of the message, usually euphemisms, which are also called as word substitutes, are used to explain the things and procedures. Okay, the dental terminology, we call it rubber dam. For children, we say rubber raincoat. And rubber dam clamp can be referred to as a tooth button, rubber dam frame as a coat rack, sealant as a tooth paint, and topical fluoride gel as a cavity fighter, air syringe, wind gun, water syringe, water gun, suction as vacuum cleaner, then alternate as pudding, and then high speed, low speed hand pieces can be referred to as a whistle or a motorcycle respectively, and radiographic equipment can be referred to as camera. Okay, so this helps the child understand these things better. Non-verbal communication, also called as multisensory communication. Here, body contact can be a form of non-verbal communication. The clinician's simple act of just placing a hand over the child's shoulder while sitting on the dental chair or stool, it conveys a feeling of warmth and friendship. Okay, eye contact is also very important. That's why we say that when you're talking to a child, usually you have to come up to their level to establish an effective communication. Sitting and speaking at the eye level allows friendlier and less authoritative communication. And active listening is also very important. Then comes a very important technique which is called tell show do. It was introduced by Edelson 1959. Here this technique encompasses several concepts of social learning theory. Okay, tell show do is a series of successive approximations. You have to tell the child what you are going to do. You have to tell what you are showing. You have to tell while you're doing, and then you have to show what you have told, show what you will do, and then do what you have told and shown. Okay, so this is how the patient develops trust on you. Okay, and gradually becomes accustomed to the procedure. In this picture you can see how the dentist is trying to explain to the child by showing things. Here you can see this is an air rotor which is being shown to the child, and you can always tell the child that it is a motorcycle, or it is a water shower which is used to shower the tooth, and water is going to come out of it. Show it on the hand first and then you put into the mouth rather than directly placing inside the mouth. So this process of telling, showing, and then doing should be continuous for the from the child's entry into the dental operatory, and through all the procedures which are being done. Okay, the main objectives are to teach the patient the important aspects of dental visit, to shape the patient's response to procedures through desensitization, and indications are all patients who can communicate regardless of the level of method of communication. Then desensitization, there's something called as desensitization. It's a format of hierarchy of steps from the least to the most stressful situation. Okay, the patient while in state of deep relaxation is exposed to one step at a time, each step presented repeatedly until there is no evidence of stress or antagonism to that particular step on the patient's part. Okay, so when the child comes to you, just do the simple things first. Just tell the child that I'm going to count your teeth today, and during the first visit, that's the reason for kids that we usually do only the diagnosis part. We can take few radiographs in the first visit, but usually we don't do any procedures. Okay, so this is how it is done. The child enters the dental operatory. You can first introduce the mouth mirror. Give the mirror. This is before even entering into the dental chair. Mirror is given to the child. Then you can place it in the mouth. Then you have to show the probe on the fingernail. Just touch it on the fingernail and show that I'm going to count your teeth like this. Okay. Then air which is used is blown onto the hand rather than directly into the mouth, and then the patient is asked to sit on the dental chair or on the parent's lap. Okay, lie in the dental chair. Then you can do the clinical examination in first visit. At the most, prophylaxis and fluoride varnish can be done, or any kind of emergency treatment if required, but not more than that. Okay, so the objective is gradual exposure of child to his or her fear so that he learns to overcome them, and it is used to restrain a child who presents with pre-established fears and uncooperative behavior, which can be a result of unpleasant dental experience earlier or negative comments which the child has heard about dentistry from the parents or siblings or peers. Okay, then comes another important technique, voice control. It is a controlled alteration of voice, volume, tone, pace to influence and direct the patient's behavior. Okay, so main objectives are to gain the patient's attention and compliance, and to avoid negative or avoidance of behavior, to establish authority. Indications are for uncooperative, inattentive patients who can communicate well. Okay. Contraindication: patients who have disability or who are on medication or are emotionally immature, who are unable to understand and cooperate. Sudden and firm commands can be used to get the child's attention. This is an abrupt and emphatic change in the dentist tone. Okay, so you have to just emphasize on the displeasure which is there due to the child's behavior. So as soon as the child complies, we should thank the child and compliment him for the resultant excellent behavior. So it's used in properly correct situations. It is an effective management tool. Then there's something called biofeedback. This involves use of certain instruments to detect certain physiological processes which are associated with fear. Like when there is fear, there is increased heartbeat, all those things. So to measure that, electroencephalogram, electromyography, all these devices can be used. Okay, devices used to measure heart rate, or you can monitor the respiratory rate. All that comes under biofeedback. Then comes audio analgesia, which is also called as white noise. It's a method of reducing pain. This technique consists of providing a sound stimulus of such intensity that the patient finds it very difficult to attend to anything else. Okay, so auditory stimulus like pleasant music can also be introduced to reduce stress and reduce the reaction to pain. Then there's another important technique, which is modeling. The basic modeling procedure involves allowing the patient to observe one or more individuals or models who demonstrate appropriate behavior in a particular situation. So here the patient is, allowed to watch a child or a sibling who's a model being treated. Okay, then the child imitates the model's behavior when placed in a similar situation. The model can be live, like in this situation you can see, or it can be filmed in a TV or animated ones. Okay, so live models can be siblings or other children or parents. So rather than making the child patient wait in the waiting room, children may be brought into the operatory immediately upon arrival. Okay, if the suitable models who are behaving in an appropriate manner are being treated. It is observed that multiple models simultaneously undergoing dental procedures seem to have remarkably calming effect on the anxious child. You can see in the picture the child is observing another patient being treated. Okay, so this child is a model, and this whole technique of behavior management is called modeling. Okay, then comes contingency management. The presentation or withdrawal of reinforcers is termed as contingency management. Reinforcers, by definition, always increase the frequency of behavior. There are two types of reinforcers, positive or negative. So positive reinforcers are the ones whose contingent presentation increases the frequency of certain behavior. Positive reinforcers can be social or non-social. Social include verbal praise, okay, facial expression, appropriate physical demonstration of affection by all the members of dental team. And non-social reinforcers include tokens, toys, all those things. Okay, then comes negative reinforcers. These are those reinforcers whose contingent withdrawal decreases the frequency of the behavior. Okay, and there are punishers are those negative attitudes actions which are used to extinguish the inappropriate behavior. It is failure to reinforce, maybe by critique of behavior or admonitions, aversive restraints, or inadequate presentation of praise. Okay, all these things. Then there's something called omission also. I'll explain in this tabular form which I have made. Okay, see, if there is a pleasant stimulus, okay, two things, pleasant stimulus or unpleasant stimulus. So if we present this pleasant stimulus, okay, and that presentation of pleasant stimulus increases the probability of the response, that is called positive reinforcement. We have positively reinforce the child. The presence of this stimulus is increasing the probability of response. If we are presenting unpleasant stimulus, and that is increasing the probability of the response, the withdrawal of the unpleasant stimulus, then that is called as negative reinforcement. That we are withdrawing a negative stimulus, okay, unpleasant stimulus, and that is increasing the probability of response, that is called negative reinforcement. Then there is something called omission or timeout, where pleasant stimulus is withdrawn, so that will decrease the probability of the response. Okay, and then there's something called punishment, where we are introducing or presenting the unpleasant stimulus. So simple thing, you present pleasant stimulus, positive reinforcement. You withdraw unpleasant stimulus, negative reinforcement. You present a unpleasant stimulus, that's called punishment, and you withdraw a pleasant stimulus, that's called omission or timeout. Okay, so this is how we manage. So the common social reinforcers are praise, like you can tell the child good, exactly, great, that's right, good job, okay, that's interesting, all those positive words, okay, that's so, thank you so much for helping so much, all those things. If you say such things, that is verbal praise. Then facial expressions, by just smiling or looking interested, okay, laughing, high five, nearness, talking continuously with the child, listening to each other for a while, eating together, playing games, all those things. Then physical contact, just sitting in lap, shaking hands, touching, patting on the shoulder or head, holding the head, hugging. These are the physical forms of social reinforcers. Okay, then contingent distraction, diverting their attention and engaging them in alternate activities like watching TV, playing video games, listening to audio tapes, stories. Distraction is thought to gain control over an aspect of patient's capability to respond. Then contingent escape. The dentists, they have long recognized that giving children a sense of trust and control is important strategy in coping with dental procedures. So using non-verbal communication techniques, like you can always tell the child that if you feel any kind of uh, pain or any discomfort, just raise your hand, okay, to allow the child to stop the treatment when they experience discomfort. Okay, this is the dentist way that they allow children to gain their trust, and instill a sense of control, that child has some sense of control over the situation. But disruptive behavior, when used to escape from ongoing dental procedures, is a natural tendency of dental surgeon to stop the procedure in response. This can serve to encourage that behavior. So that should not be done. Escape is not allowed in dentistry. You have to do some procedure and send the child. Okay. Otherwise, it will become a habit. Then comes another important method, hypnosis or suggestion therapy is a technique by which a state of altered consciousness is produced without the use of pharmacologic agents. Okay, generally hypnodontics may be applicable for child patients with whom communication is possible. The use of hypnosis in dentistry is sometimes referred to as hypnodontics. Communicative children, teenagers are good hypnodontic subjects because they are familiar with pretend games and they are readily influenced by suggestions from adults. Hypnosis, however, is usually not taught in dentistry and dental schools. So, uh, we usually don't apply it that much in clinical practice. Okay, but it is one of the methods. So, just remember that. Then comes coping. It is a mechanism by which child copes up with the dental treatment. It is defined as cognitive and behavioral efforts made by individual to master, tolerate and reduce stressful situations. So patient under stress prefers to draw comfort or reassurance from an authoritative figure, thus establishing a close or trusting relationship with a doctor or nurse. Coping may be of two types, behavioral or cognitive. Behavioral are physical and verbal activities in which the child engages to overcome a stressful situation, and cognitive is where the child may be silent and thinking in his mind to keep calm. Okay, cognitive coping strategies can enable the children to maintain a realistic perspective on the events at hand, okay, which is reality oriented working, or perceive the situation as less threatening, which is called cognitive reappraisal, or it calms and reassures that everything is going to be all right. That is emotional regulating cognition. So child might be thinking of all these things in his mind. That is cognitive coping. Then comes distraction. Distraction is simple. You just have to divert the patient's attention from what may be perceived as unpleasant procedure. This can be done by playing music or showing them some videos, talking to them, white noise, hypnosis, asking them to take deep breaths. Okay, audio visual aids you can see in this picture. Objective is to decrease the perception of unpleasantness. Okay, it may be used in any patient. There's no contraindication as such. Then comes timeout. It involves temporarily separating a child from an environment where inappropriate behavior has occurred, and it is intended to give an overexcited child a time to calm down. It is an educational and parenting technique as well. Okay, and it's often a corner or a similar space where the child needs to stand or sit during the timeout. It is designated, and timeouts are recommended for younger children. Okay, then comes physical management. Physical management also described as flooding technique or aversive conditioning. There are two basic or most important techniques which you have to remember here, which are hand over mouth exercise, also termed as home, and physical restraints. Okay, so hand over mouth exercise was introduced by Evangeline Jordan, who wrote that if a normal child who is not listening but continues to cry and struggle, hold a folded napkin over the child's mouth gently but firmly. Hold his mouth shut. His scream increases with the his conditional hysteria, but if the mouth is held firmly closed, there's little sound and soon the child understands and begins to reason. Okay, and this was described by Levitas as hand over mouth technique or hand over mouth exercise, the term which was given. So a hand is placed over the child's mouth and behavioral expectations are calmly explained to the child. The child is told that the hand will be removed as soon as the appropriate behavior begins. Okay, so when the child responds, the hand is removed and appropriate behavior is reinforced. So the need to diagnose and treat as well as safety of patient and practitioner must justify the use of this technique. The decision to use is dependent on a lot of things. Okay, you have to choose from the other alternate behavior modalities. If nothing is working, then you have to go for this. Patient's dental needs, quality of dental care, patient's emotional development, patient's physical considerations have to be taken into consideration. Parents or guardians consent should be obtained prior to use of this technique. Informed consent and indication for the use should be explained and included in the patient's record. Okay. The objectives are to gain the child's attention, enabling communication with the dentist so that appropriate behavioral expectations are explained. to eliminate inappropriate avoidance response to dental treatment, to establish appropriate learned response, to enhance the child's self-confidence in coping with the anxiety-provoking stimuli of dental treatment, to ensure the child's safety in delivery of quality dental treatment. You can see in here in these pictures how technique is applied. Indications are in a healthy child who is able to understand and cooperate, but who exhibits defiant, obstreperous, and hysterical avoidance of behavior to dental treatment. Contraindications are in children who, due to age or disability or medication, who are on medication, have some sort of disability, or very young in age, or have emotional immaturity. They are unable to understand and cooperate. So we can't use this technique in them. Okay. And also it should not prevent the child from breathing. So we don't have to cover the nose. However, there are certain variations. Okay, the variations are hand over mouth, airway unrestricted. Here only the mouth is covered. Then hand over both mouth and nose. Here the airway is also restricted. Then towel held over mouth only. Then dry towel which is held over mouth and nose. Wet towel which is held over mouth and nose. So although these are the variations, but it is always recommended that hand should be placed only on the mouth, and child's airway should never be restricted. Okay, because it's very important to ensure that child has no nasal blockage also, and can be satisfactorily the child can breathe while the mouth is shut. Okay. Then comes physical restraint, partial or complete immobilization of the patient. Sometimes it's very necessary to protect the patient and dental staff from injury while providing the dental care. Physical restraints in dental office can range from gently holding the child's hands during injection to fully body restraining the child with a papoose board. Okay, restraints can be performed by dentist or the staff or parents with or without the aid of a restraining device. Restraints, when used, parental or guardian consent must be obtained prior to its use. Okay, it can involve the consent. It must be included in the patient's record, informed consent, type of restraint which is used, the indication of restraint, and the time for which the restraint was used. All these things should be recorded. Okay. Objectives are to reduce or eliminate untoward movement, to protect the patient and the dental staff from injury, to facilitate delivery of a quality dental treatment. Okay. Indications: a patient who requires diagnosis or treatment and cannot cooperate due to lack of maturity, a patient who requires treatment but cannot cooperate due to mental or physical handicap, or does not cooperate due to behavioral other cannot cooperate even after applying other behavioral management technique, and when the safety of the patient or practitioner would be at risk without use of proper restraint. Contraindication: a patient who is already cooperative, it's not required, and a patient who cannot be restrained safely due to some medical or systemic conditions. Okay. Commonly used physical restraints are the mechanical aids which are used to maintain mouth in an open position. Okay. Restraints for body, for extremities, and for head. Okay. So these are the mechanical aids which you are used to maintain the mouth in open positions. Padded or wrapped tongue blades, they are easy to use, disposable, they are reasonable. Then there are mold mouth props, very helpful for managing difficult patients, and made in both adult and child sizes. Allow accessibility to opposite side, operates on reverse scissor action. Disadvantage includes the possibility of lip and palatal lacerations can occur, and also luxation of teeth if in children if they are not properly used. You can see in this picture, this is the one which works on that reverse scissor action. Okay, physical aids to keep the mouth open. This is a mouth prop which is used, mouth block which has a suction tip also incorporated into it, and this is the simple tongue blade for retraction. Okay, then this is a finger guard or intraocclusal thimble. Okay, all these. Then rubber bite blocks like these can be used. There are restraints for the body. This is a papoose board. It is commercially available wrapping for the body. You can see in this patient has been restrained using a papoose board. Okay, the advantages are it's simple to store and use, available in all sizes. Okay, has attached head stabilizers. It is reusable, but disadvantages are that it does not always fit the contours of the dental chair, and sometimes a supporting pillow is needed since it covers the patient's diaphragm. So respiration has to be monitored, and especially if we are using in combination with sedation. Okay, and in extremely resistant patient, the patient might develop hyperthermia if it is used for a long period of time. Okay. Then there is a triangular sheet in which nothing but a sheet is used to tie the child like this. It is used in controlling extremely resistant child. It allows the patient to sit upright during radiographic examinations. The disadvantage is that frequent need of straps to maintain the patient position in the chair. It's difficult to use in patients who are younger, and possibility of airway impingement if the patient slips downward unnoticed, that then it might impinge on the airway, and there's a possibility of hyperthermia. Then there's something called pedirap. Pedirap does not have head supports or backboard. Okay, it comes in various sizes. It allows some movement while still confining the patient to the dental chair. So because of its mesh net fabric, it permits better ventilation. So there is less chances of hyperthermia. You can see this is how the extremities are wrapped. So this is called pedirap. Can be used for any of the limbs. Okay, disadvantages that it requires straps to maintain body position in dental chair and constant supervision to prevent the child from rolling out of the chair. Okay, then these are the different sizes of the papoose board which you can see. Okay, for body and extremities with the head restraints as well. Small size is available, regular, large, extra large. This is a head positioner. Okay. Then there is something called beanbag dental chair insert. It is a beanbag like of thing which is inserted into the dental chair. Okay, and child can comfortably sit in the beanbag. It is reusable, washable, and one size usually fits the patient. So child is more comfortable sitting on this. There is a safety belt kind of a thing which is there to prevent the child from slipping or rolling down. Okay, and extra assistance can also be taken either from the parents or the dental assistant. Okay, there are resistant restraints for extremities like posy straps. Okay, and towel and tape, velcro straps, etc. This is extra assistant. You can see the child is sitting in the dentist's lap and the mother is holding the hands and the legs. Okay, here the child is sitting in the mother's lap on the dental chair. So this is extra assistance for immobilization of the patient. Okay, the restraints for head, you can see this is the restraint which is used, head positioner. Okay, so these are the different types of restraints which are used. Then there's something called as implosion therapy. It is a technique used in behavior management in which the child is flooded with experiences of a particular kind until he becomes either averse to them or is numb to them. Child is left with no other choice but to face them. So it mainly comprises of combination of home, physical restraints, voice control all together. Okay, but it's very rarely used because it becomes very aversive type of therapy. Then there is snoozling environment. It has been introduced recently. It is an environment in which there is, a partially dimmed room with lighting effects and vibroacoustic stimuli and deep pressure. So it has a very calming effect. Okay, it minimizes sensory discomfort, distress, and perception of pain during the dental procedures, and it is specially used in children who are autistic or have some sort of disability. It works really well, and a lot of pediatric dentists are using this as a behavior management technique. Okay, so to conclude, I would say that there is no one method which is applicable in all situations. Appropriate management technique should be chosen based on the individual child's requirement and the individual dentist experience and expertise in the non-pharmacological behavior management technique. Okay, now quickly I'll discuss one or two questions. So there's a question A child behaves inappropriately during his dental visit. So in response, the dentist sends the mother outside the operatory. This kind of behavior management is termed as A. Positive reinforcement, B. Negative reinforcement, C. Punishment, or D. Omission. So you have to remember from that table which I explained. Okay, here we are removing the pleasant stimulus S1. Okay, you are removing or withdrawing that stimulus so that the positive behavior is repeated or the negative behavior probability decreases. So this is called omission. Okay, so if we are sending the mother out of the operatory, that is called omission. Okay, then another question is most commonly used scale for behavior rating. I have not discussed about behavior rating in this because we had less time. Okay, so behavior rating, there are a lot of scales which are used to rate the behavior of the child, but the one which is most commonly used is a Frankel's behavior rating scale. Just go through all the scales once. Frankel's behavior rating scale describes child's behavior as positive, negative, okay, definitely positive, definitely negative, all those. So based on that, that is the one which is easiest to use. So that is the one which is most commonly used in dentistry. Okay, so that was all in brief about non-pharmacological behavior management techniques. Thank you so much for listening. If you have any doubts, do let me know. All the very best for your exams. Thank you.